Thank you for joining us for today's webinar, Cervical Cancer Screening for Vulnerable Populations. My name is Jessica Monmany, and I am the Senior Education Associate at ARHP. I will be moderating today's webinar. Before we begin, I'd like to share how you can receive your continuing education credit. In order to receive credit, you must take the pre- and post-test. If you have not yet taken the pre-test, please click the link provided to you in the reminder email or via the webinar's chat box. About an hour after the conclusion of this webinar, you will receive an email from Caitlin Borsowitz, ARHP's Communication and Education Associate, with a link to the post-test survey. Your continuing education certificate will be generated upon completion of that survey. In 4 weeks, you will receive another email with a link to a follow-up evaluation. Please complete this evaluation to let us know how you've incorporated what you learned during this webinar into your work. Completing the pre- and post-test, as well as this follow-up evaluation, helps ARHP ensure we continue to meet your educational needs and interests. Thank you in advance for your time and feedback. At this time, I would like to introduce Dr. Tonya Poteet and Jill Crank, today's presenters. Tonya Poteet is an assistant professor with the Center for Public Health and Human Rights, as well as the Center for AIDS Research in the Department of Epidemiology at Johns Hopkins School of Public Health. Dr. Poteet graduated from Yale University with a bachelor's degree in biology in 1991. She completed her PhD in International Health at Johns Hopkins Bloomberg School of Public Health in 2012 and has over 20 years' experience as a physician's assistant. Jill Crank has been providing comprehensive primary care, including women's health services, transgender care, and HIV treatment and prevention in Baltimore for almost 10 years. She earned her joint Master of Science in Nursing and Master of Public Health degree at the Johns Hopkins School of Nursing and Bloomberg School of Public Health. She's board certified as a family nurse practitioner from the American Nurses Credentialing Center and is an adjunct faculty member at the Johns Hopkins University School of Nursing. We're pleased to have them both with us today, and Tonya, you have the floor.
Great, thank you. First, I'd just like to acknowledge that this program was made possible through an independent educational grant from Roche Pharmaceuticals. Okay. I'm not sure that I am in control of the controls. And then I just wanted to, before we go through the learning objectives, to say that we want to put forth a disclaimer regarding gender-sensitive terminology. Where appropriate, we've changed the subject to be patient rather than woman to respect other gender identities of people who are still at risk for cervical cancer. But it's not always possible to do this when summarizing research studies where the results were reported as women. So we don't mean for this language to be offensive or exclusive, and we encourage feedback on this presentation in that regard. So moving forward from that, our learning objectives are going to be to do a brief overview of HPV and current cervical cancer screening guidelines, to identify vulnerable and underserved populations and describe relevant barriers to cervical cancer screening and treatment, to describe and apply the ASCCP and other applicable screening guidelines for vulnerable and underserved populations, and to apply appropriate counseling techniques and patient management for vulnerable and underserved populations. So virtually all cervical cancers are associated with persistent infection with high-risk HPV. A variety of studies have confirmed that certain HPV types are associated with cervical cancer, and you can see the long list that appears right there. But overall, 70% of cervical cancers are from type 16 and 18. In practice, when you do cytology and the reflex HPV is ordered, typically the test comes back saying one of the high-risk types has been identified, but it doesn't tell you which one. If appropriate, based on guidelines, you can order genotyping for HPV 16 and 18 as an add-on to an abnormal cytology to help determine the next steps in management and treatment. I'm trying to advance the slides, but oh, I guess it's delayed. Okay. There are 14 million new infections of HPV, and approximately 79 million people in the U.S. currently are infected with HPV. And by age 50, 80% of sexually active women will have acquired genital HPV infection, so it is incredibly common. In fact, the lifetime risk of HPV infection is about 75% for sexually active individuals. I apologize. There will be apparently some random slide movement that I may or may not be able to control. So while HPV infection itself is very common, it is persistent HPV infection that leads to precancerous changes in the cervix. Persistent infection is defined as the detection of the same HPV genotype 2 or more times within a given interval of time. However, the duration of the time defining persistence hasn't been agreed upon. Only a small minority of women with HPV by DNA assay have microscopic cervical abnormalities, but as many as 25 to 40% of women who are cytologically normal but HPV positive will develop cervical abnormalities when they're tested 1 to 3 years following. So these data point to the importance of persistence of HPV infection. And within 2 years, about 90% of HPV infections are cleared by the immune system. It's the remaining 10% of infections that persist and are strongly linked to high risk of precancerous changes. This is data from the American Cancer Society that indicates that in 2017, they estimate that there will be about 12,820 new cases of cervical cancer, and over 4,000 people will die of cervical cancer. However, within the 4,210 people who will die, there are significant disparities in the groups, especially by race and ethnicity. The highest mortality is in African American women in the South, Latina women along the Texas and Mexico border, white women in Appalachia, American Indians of the Northern Plains, Vietnamese American women, and Alaska Natives. So one of the most important ways to reduce incidence and mortality is by ensuring that there's adequate cervical cancer screening. What you see here are the guidelines that are adopted by the American Cancer Society, the American Society for Colposcopy and Cervical Pathology, and the American Society for Clinical Pathology. These guidelines are intended for the general population and will discuss some differences that exist for vulnerable populations. And you'll see here that no screening is recommended below the age of 21 years. From age 21 to 24, cytology every 3 years is recommended without HPV testing. Between the ages of 25 and 29, cytology reflects HPV every 3 years is recommended. Over age 30, cytology plus HPV every 5 years, or cytology alone every 3 years. And after age 65, no screening after adequate prior negative screening results. And no screening is recommended after hysterectomy unless the person has had a prior CIN2. So Healthy People 2020 are targets that are established by the federal government for the general population, and they cover a variety of preventive care targets. And you can see here several cancers that are listed, and in the middle column is the target rate for recommended by Healthy People 2020, and in the far right column is the overall screening rate from the most recent data we have from 2013. And you can see, while the target rate for cervical cancer is 93% screened, the overall screening rate in 2013 was less than 81%. The question is, why do we have this disparity between the targeted screening and the actual screening, and what can we do to help improve these rates? So we're going to talk about vulnerable and underserved populations and how we can help engage them in preventive screening and care. When we talk about vulnerable and underserved populations, for this conversation we're going to focus on racial and ethnic minorities, sexual and gender minorities, as well as individuals who are immune compromised, experiencing homelessness, have a prior history of CIN2 or higher, or have had a history of in utero DES exposure. So if we look at the general population statistics in the United States, you can see that blacks or African Americans make up about a little under 14% of the population. Hispanic or Latino identified people make up a little over 17% of the population. People who identify as Asian alone make up 5.6% of the population, and under 2% identify as American Indian or Alaskan Native alone. And these are data that are usually collected by the census. Historically, data on sexual and gender minorities has been difficult to come by. However, recent changes in how federal and national statistics are gathered provide us with an opportunity to have more population-based statistics on this population. In fact, an organization like the Williams Institute, which is an LGBT research center in Los Angeles, has generated some very helpful information based on statewide statistics. And they estimate that there are 3.4% of women identify as lesbian or bisexual, representing a little over 4 million people in the general population. 3.6% of people are gay or bisexual men, over 4 million people in the population. And most recently, in their 2016 report, they identified that 0.6% of the U.S. population identifies as transgender, representing 1.4 million people. There isn't nationally available statistics on intersex populations, and intersex is defined as a term that's used for a variety of conditions in which a person is born with reproductive or sexual anatomy that doesn't seem to fit typical definitions of male or female. There is an organization that's now defunct called the Intersex Society of North America, and it maintains a historical website that has data on the estimated number of intersex people in the United States, and they estimate anywhere between 1 in 500 or 1 in 2,000 newborns are born each year with an intersex condition, depending on what conditions are counted under that category, as well as other factors. The most recent data indicate about 1.2 million people over 13 years old are living with HIV, and 1 in 4 of them are women, and about 40% of the general population is homeless. So we'll focus first on racial and ethnic minorities. You can see here how the data has been provided in the national statistics on screening Pap smears among racial and ethnic minorities, and this is the percent of people who've had a Pap test within the last 3 years consistent with the current guidelines. While it's not depicted here, the overall cervical cancer screening rates have actually declined from when data were collected in 2010 and when they're depicted here in 2013. As you might remember from the previous slide, the goal is 93% of cancer rate screening, and you can see that none of these groups actually meet that goal. However, some groups are lagging farther behind than others. You can see that whites, blacks, American Indians, Alaskan Natives, and Puerto Rican patients had the highest rates of screenings with over 80%. And if you combine race and ethnicity, white non-Hispanic patients had the highest rates at 83%, and black and African American non-Hispanics at 82.3%. American Indian and Alaskan Natives had only 82.1%, and Hispanic or Latino and Asian patients had similar rates, as you can see listed here. So in summary, within the category of Asian, Chinese patients had the lowest rates of cervical cancer screening at 64%, and then Hispanic women had a rate of 76.9%. For patients who were born in the U.S., the rate of screening was 82%, and this is in comparison to 66% for those in the U.S. who were in the U.S. for less than 10 years and 77% for those who were in the U.S. for more than 10 years. So the longer someone has residence in the United States, the higher their rate of screening. When we look at data on African Americans, the data often doesn't discriminate between African-born and American-born black patients. But there are reasons to pay attention to this subgroup, including the fact that there are higher rates of high-risk HPV infection in women from sub-Saharan Africa who may immigrate to the U.S. and have never had a Pap smear due to lack of access or difficulty with getting health care. The NIHS data from 2008 to 2010 have indicated that African American women were 3 times more likely to report a current Pap smear, i.e. within the last 3 years, compared to African-born women. So we do see some disparities there, and it's important to pay attention to country of origin. The data that's provided on this slide has been age-adjusted to the 2000 census of the U.S. population and their rates per 100,000. you can see that patients who are Hispanic, non-Hispanic, Black, American Indian, or Alaskan Native have higher rates as well as incidence and death for cervical cancer. Non-Hispanic Black patients have twice the rate of death compared to non-Hispanic whites. And at the end of January this year, a groundbreaking article was published by folks from Hopkins in the Cancer Journal that re-examined cervical cancer mortality rates by removing women who had hysterectomies and therefore would not have had a cervix. They found that the racial disparities between Black and white women were larger than previously thought, with the rate of 100,000 people being 10.1 for Black women and 4.7 for white women, representing a 44% underestimation of mortality rates when you look at the data that had not removed women who'd had hysterectomies. Also not on this infographic, African-born Black patients had cervical cancer rates of up to 3.5 per 100,000 in Eastern Africa compared to African-American Black patients in the U.S. at a rate of 9.4 per 100,000. With a growing number of immigrants from Africa, there is a potential for many of the disease characteristics that affect women in that region to also influence the health of African-born women who are now living in the United States. These differences in mortality rates are not thought to be due to inherent biological differences in response to treatment, but reflect a lack of access to treatment due to a variety of factors. So what are the barriers for screening for racial and ethnic minorities? And you'll see a list here, and I'll dive a little bit into some of those. Lack of citizenship or documentation and lack of health insurance are associated with lower pap smear screening rates. And this reflects difficulty in accessing affordable care as well as culturally sensitive care. Language barriers have been shown to reduce screening rates as well as levels of acculturation being associated with screening rates. And acculturation is a multidimensional concept that's intended to reflect the complex process of adaptation between groups of different cultural backgrounds. So if someone grew up outside of the United States and then came to the United States, they would be in a process of acculturating to the culture of people in this country. It's typically measured by the number of years living in the United States and whether or not the patient speaks a native language that's not English. In general, more acculturation is associated with speaking English and a higher number of years in the United States. And that has been associated with higher screening rates for cervical cancer. Lack of knowledge about cervical cancer screening and cervical cancer itself can be a huge barrier. Studies have shown that African American women have less education around HPV as a cause for cancer and about sexual transmission of HPV. They may be unaware that cervical cancer screening is not required if you've no longer had a cervix. There is evidence that Hispanic patients have had less information about cervical cancer screening due to language barriers, but may also be impacted by cultural factors such as fatalistic beliefs that cervical cancer may be predetermined or a punishment for something. Medical mistrust is common particularly among communities of color due to fear of being stigmatized, previous negative experiences, or worry about being treated differently. Histories of trauma like sexual abuse, intimate partner violence, or even trauma in a medical setting can negatively impact women's willingness to seek cervical cancer screening. So what can we do about that? So the biggest recommendation is to recommend screening, to provide the education and information that people need in order to know that they do need screening. Studies show that women who did not receive recommendations from their healthcare providers are less likely to receive screenings. So even if you see someone for an acute visit, it can be very helpful just to take a look at their preventive care milestones and ask if they've had a pap smear in the last few years. And if they are someone who needs pap smear screening, then to recommend that. A systematic review of the literature in 2012 was performed to determine which interventions would improve screening, and they found that there was a moderate strength of evidence that telephone support with navigation increases the rate of screening in Spanish and in English-speaking populations. And many studies have shown that educational outreach using peer navigators of a similar race or ethnicity, as well as a similar gender, increase pap smear screening success. It's also important if someone hasn't had a pap smear to elicit from them their beliefs about cervical cancer screening, who's at risk, why they get the test, and to normalize the intervention, particularly for patients who are from a culture or country that where cervical cancer screening isn't common. When working with patients who do not speak English as their first language or who have language barriers, it's important to use interpreters instead of family members when working to communicate with them. And this is generally accepted practice to respect the privacy of the patient. You want to make sure that they get information that's not filtered through maybe the family member's opinions about what's being offered, or maybe even medical terminology that the family member might not understand and be able to translate appropriately. You want to assess who else should be involved in their decision making. Is there a partner, another family member, or a friend who should be involved in making decisions with them? In many cultures, due to modesty, distrust, or other cultural taboos, women are not comfortable with male clinicians. So even fabulous male clinicians may not be acceptable to the patient. So having relationships with trusted female clinicians that you can refer the patient to can be very helpful. Participating in community events to provide educational outreach can be very helpful, especially for people who are not engaged in primary care. Being able to refer people to special programs that help provide free or low-cost screenings, such as the CDC's National Breast and Cervical Cancer Early Detection Program, fairly qualified community health centers and health departments can be very helpful. And then training and hiring racial and ethnic minority clinicians so that people can see other people who look like them when they come for care can also be very helpful. So moving on from racial and ethnic minority populations to sexual minority women. As I mentioned before, data is limited on sexual minorities and practices of preventive health screening because there hasn't historically been that kind of data collected. However, where there is data, in general, studies show that sexual minority women, and that's any sexual orientation that's not heterosexual, tend to be screened at lower rates than heterosexual women. However, it's important to remember that HPV can still be passed from woman to woman, and also to remember that sexual orientation can be fluid. So a woman who identifies as a lesbian today may have had male partners in the past and may have male partners in the future. We know that lower income and lack of insurance is associated with lower screening rates in this population. And we know that HPV has been detected in up to 30% of sexual minority women, including women who report never having had a male sexual partner. And precancerous cervical lesions have been detected in sexual minority women who've had no previous sex with men. So regardless of the patient's sexual history, they still are someone who needs to be screened for cervical cancer. So what are some of the barriers for screening among sexual minority women? A lack of perceived risk, both by the provider and the patient. So the patient may believe if they haven't had male sexual partners that they're not at risk for HPV or cervical cancer, or they may believe even if they have, their identity as a lesbian is protective to them. They may have also received information from an uninformed healthcare provider who told them that they were not someone who needed cervical cancer screening because they identified as lesbian or had not had a male partner. Often sexual minority women are absent in public health messaging around cervical cancer screening, so they are invisible and don't see themselves reflected in those messages about people who need cervical cancer screening. And there's also a potential fear of discrimination in healthcare settings due to their sexual orientation, and they may avoid healthcare altogether. However, current screening guidelines recommend that cervical cancer screenings be routinely offered to all patients, regardless of their sexual orientation. The USPSTF is actually the only recommended body that mentions sexual minority patients. And in other guidelines where there isn't a distinction made, they also don't explicitly say that that screening should be the same for sexual minority patients. And there are some advocates who are working to try to make sexual minority patients more visible in these guidelines. Recommendations for improving cervical cancer screening among sexual minorities includes making the healthcare environment more welcoming, posting signs of non-discrimination policies, putting up advertisements that include visible lesbians or bisexuals so that they can feel included and reflected and welcome in the environment is important. Incorporating sexual minority terminology and history taking, so avoiding assumptions that the person has a male partner by using terms such as husband or boyfriend, but using things more open like partner. Helps the patient to know that you're not assuming anything about their sexual behavior or their sexual identity. It's important when you ask open-ended questions to be ready for any answer, including that the patient may have more than one partner at a time, and they may have partners of more than one gender. Taking this kind of sexual history provides an opportunity to educate the patient about their risk, especially since many sexual minority women may assume that they are low risk. It's also an opportunity to correct any misconceptions they may have about cervical cancer screening and cervical cancer risk. It's also important to increase education specific to sexual minority women, and you'll see on the right-hand side of your slide, there is the icon for GLAMA, Health Professionals Advancing LGBT Equality, and on their website they have information for healthcare professionals. They also have information for patients, including sort of top 10 concerns that lesbians should discuss with their healthcare providers. You'll also see an icon for the National LGBT Education Center, which is a program of the Fenway Institute in Boston, and they have just a plethora of helpful information and educational materials both for patients and healthcare providers, and you'll see their website listed there. Moving on to transgender men, the majority of transgender men do retain their cervix, so they don't have surgery to remove the cervix. And transgender men are people who are assigned female sex at birth but are currently identified as male. And if they retain their cervix, they're still at risk for HPV changes as well as cervical cancer. In a study that was done at the Fenway Health Institute, which is Boston's largest LGBT health center, they found that transgender men had a 30% lower odds of being up to date on their cervical cancer screening compared to non-transgender female patients. This was surprising since the Fenway Health Institute is sort of world-renowned, if not nationally renowned, for being for the quality of their LGBT-related care. So likely that means that if there's a 30% lower rate, 37% lower rate at Fenway Institute than in other centers that don't focus specifically on LGBT populations, that rate may be even lower. We also know from a study that was conducted at Fenway that transgender men are about 8 times more likely to have unsatisfactory or inadequate PAP results due to effects of testosterone on the cervix. This lower rate may also be because of provider and patient discomfort during the exam that can lead to suboptimal samples, things like scant samples, acellular samples, and inadequate findings. If that happens, if somebody has an insufficient sample or unsatisfactory sample, it requires repeat testing within 2 to 4 months, according to ASCCP guidelines. Some of the screening barriers for transgender men include a history of negative healthcare experiences. The U.S. survey that was conducted by the National Center for Transgender Equality included over 27,000 transgender people during the summer of 2015, and they recently published their findings. And they found that 1 in 3 trans patients reported having a negative experience or actual discrimination from a healthcare provider in the prior year. And this included being refused treatment, being verbally harassed, and even being physically or sexually assaulted. The most common negative experience that people have is having to teach their healthcare provider about how to deliver transgender-related care to them. The survey also showed that 13% of transgender people had been denied coverage for preventive services like pap smears, as well as prostate exams, mammograms, etc., simply because of their gender. The Affordable Care Act does mandate that insurance companies provide preventive services regardless of gender, but in practice, many insurance organizations still send letters denying or questioning a cervical pap smear being done in a patient who has a male gender identity. This may require you to call the insurance company or send back certain billing codes to explain the requirement for coverage. It also helps to explain that this may happen to the patient ahead of time so that it doesn't interfere with their willingness to have the screening done in the future because they know what to expect. Also, some trans men may not believe that they are at risk for cervical cancer if they've never experienced penetration or don't have vaginal sex, or if they've only had female partners. And just like with sexual minority women, it's important to remind them that cervical cancer screening is recommended for everyone, and that cervical cancer and HPV changes have been found in people who have not had vaginal penetrative sex. Gender dysphoria is often a big reason that trans men may avoid cervical cancer screening, because this is a time when they are often reminded of the mismatch between their gender identity and their anatomy. This can be very upsetting to patients, and it could be a big reason why trans men may not stay up to date on their cervical cancer screening. And if you go to the Fenway website, they have really great guidelines on ways to make the exam itself more comfortable and acceptable to transgender men. So the American College of Obstetrics and Gynecology does recommend that transgender men with the cervix follow the same screening guidelines as non-transgender women. And this is important also when talking with trans men about screening, because referring to guidelines that talk about sexual minority women may be unacceptable for someone who identifies as a man, but these guidelines specifically speaking of trans men can be very helpful. Other guidelines are available, as I mentioned, specifically from GLAMA and from the National LGBT Health Education Center, but also the World Professional Association for Transgender Health publishes standards of care that they update on a regular basis. Their most recent guidelines were published in 2011, and they're in the process now of updating the guidelines, and we expect to see those out either later this year or early 2018. Some of the recommendations for improving care for transgender men seeking cervical cancer screening is asking and using their preferred pronoun in their names, as well as asking patients what anatomical terms they prefer to use to describe their bodies, taking a thorough sexual history and providing factual information, asking what makes them more comfortable, and there is some data on self-collected PAP and HPV swabs, sometimes offering to have the patient be able to put the speculum in themselves can make the patients more comfortable. And just simply negotiating with the patient what they feel comfortable with and having that conversation so that they know that you're going to work with them to try to get the screening that they need. It's also important to share information about how exposure to testosterone may affect the adequacy of the PAP, and letting them know that there is a chance they might need repeat PAP screening so that they're prepared for that. For transgender women, most transgender women do not have vaginoplasty, so they don't have a neo-vagina constructed. Surgeries are still inaccessible for many people, and some people don't want that type of surgery. However, HPV infection is still possible in the neo-vagina. Typically, a penile inversion technique is performed where penile skin is used and no cervix is created. However, a small number of trans women have colon tissue that's used to create a neo-vagina if they have genital surgery. And even with those surgeries, no cervix is created, but HPV infection is still possible. It's not recommended to perform pap smears in women with neo-vaginas, but it is reasonable to do visual inspections through pelvic exam. I'm going to turn it over to Jill.
All right. Okay. So I'm going to go ahead and the next and last section will be on some of these vulnerable populations. So patients who are immunocompromised are those who are living with HIV, organ transplant, lupus, inflammatory bowel disease, or any condition that requires chronic immunosuppressive therapies. And cancer screening in these populations has actually been debated and insufficiently studied, except for people living with HIV. So it's been challenging to develop evidence-based guidelines for these populations. So we're going to touch on the people living with HIV and those who have had solid organ transplants. So just so we're on the same page, HIV is a virus that affects the immune system by infecting CD4 cells, which are a type of white blood cell responsible for fighting off infection. So by definition, people with HIV are immunocompromised. Invasive cervical cancer is actually an AIDS-defining illness, regardless of the person's CD4 count. And it's been shown that HIV-infected women have a higher risk of multiple HPV infections, persistence of HPV, and increased risk of progression to precancerous or cancerous lesions. And one study did show that the incidence of CIN was 4 to 6 times higher. Prevalence rates of abnormal PAPs have been found to be about 38%, with about 20% of those being ASCUS. And in women with lower CD4 counts, like less than 500, the prevalence of HPV is higher and progression to CIN even faster, and it's worse for those who have CD4 counts under 200. Despite federal funding to provide care to all people living with HIV, approximately 20 to 40% of women in one study were found to not be screened appropriately. So the screening barriers for people living with HIV are pretty similar to the general population, like Tonya discussed. Lack of health insurance, financial instability, lower education, lack of employment. But there are a few here that are specific to this population. So when the CD4 count is lower, not only is someone more at risk for cervical cancer, but they're also at risk for something called opportunistic infections. And this is related to their HIV, and it could be pneumonia, brain infections, candidiasis, etc. So they may be really ill and in and out of the hospital, and so cervical cancer screening could fall down on the priority list in terms of medical necessity. Also, patients are less likely to receive Pap smears if they don't have a medical provider who does both HIV and gynecological care. And it's related to convenience and building trusting relationships with medical providers. Substance use and severe depression are also found to correlate with lower Pap smear rates, conceivably due to lack of consistent engagement in the healthcare system. And then also pain and discomfort with Pap smears was found to have lower Pap smear rates. So if we look at the guidelines, can you help? I think the ones, there we go. All right, cool. So if we look at the guidelines, there are 3 different bodies that produce guidelines. Hang on one second. All right, I was told that because there's a lot of graphics that delays the switch. Okay. So these guidelines we're going to look at here are published last year by the Panel on Opportunistic Infections in HIV-Infected Adults and Adolescents, which is a group of people from CDC, NIH, and the HIV Medical Association. And they published just general HIV care guidelines on AIDSinfo.gov. So ACOG also adopted these in a practice bulletin in October of last year. Among the 3 groups who do publish screening and management guidelines, like ASDCP, ACOG, and the panel, there's been varying levels of agreement over the years, and these current guidelines have evolved based on balancing research of risk for HPV and cancer, as well against cost effectiveness and burden of screening and intervention to the patient. So we used to screen every year, but after extensive review of risk and cost effectiveness, the intervals have been extended. So for people living under 30 years old, the initial screen should be within 1 year of onset of sexual activity, but no later than 21. So this is different because you can screen them under 21 years old. Between 21 and 29, you can do 3 consecutive Pap smears yearly, and if all of those are normal, you can then go ahead and screen every 3 years. And we do not do HPV co-testing due to the high prevalence in this group. For those who are over 30, you can do the same thing. You can do 3 consecutive cytology screenings, and if all of those are normal, you can then go to Q3. But you can also do co-testing, and this is new. So if you do co-testing and you have normal PAP and negative HPV, you can then extend for 3 years instead of doing 3 PAPs in a row. You do not stop screening at 65, nor post-hysterectomy in people living with HIV. So in terms of management, there are some differences in the guidelines, and the panel's a bit more conservative in how they manage the findings. So for any age group, those who have ASCUS, if an HPV test is available and it's positive, the recommendation is straight to colposcopy. If HPV is not done or it's unavailable, then you should repeat cytology in 6 to 12 months, and if you get ASCUS or worse, then you do go to colposcopy. For any group of patients who have LSIL, ASCH, AGC, or HSIL, regardless of HPV, go to colposcopy. And those who have had a normal Pap test but positive for HPV should have a repeat co-testing in 1 year. And then if any of those tests are abnormal, go to colpo. If the HPV typing for 16 and 18 happened to be done and those were positive, you should then go to colposcopy. So ASCCP and ACOG differ a little bit. Between 21 and 24-year-olds, for ASCUS and LSIL, they follow ASCCP guidelines. So you can see that you don't proceed to colposcopy right away with everyone. So if you have a high-risk HPV test that's positive, you follow up with cytology in 12 months. And then if you have nil, ASCUS, or LSIL, then they repeat again in 12 months. If you have ASC-H, AGC, or HSIL, the colpo is recommended. For those who are 25 or older, ASCCP mostly agrees with the panel in the sense that LSIL would get colposcopy, but if there happens to be a negative HPV test, they actually prefer repeat co-testing at 1 year. And ACOG, though, specifically agrees with the panel in that any woman with LSIL above 24, regardless of HPV, should go to colpo. And ACOG does state also that women infected with HIV who receive regular screening and treatment have a similar incidence of invasive cervical cancer compared to women who are HIV negative, which is great to hear. So recommendations are to, when possible, combine the HIV care with gynecology services. And if that's not possible with one practitioner, maybe there's a clinic where the services exist in one building. And if not, then systems should be in place, or patient navigators that can track who's had PAPs and who needs them. And then, as Tonya has mentioned, we should really be focusing or just scanning the chart to see where they are in terms of preventive care and trying to bring up the need for screening at every visit. And keep in mind that mental health issues and substance use may be barriers to cancer screening, and so referring to behavioral health would be helpful. And if anything, just remember that people living with HIV, there are alternate guidelines, and the main points are that you start screening under 21, you extend beyond 65 or after hysterectomy, and that there are some nuances in how you manage abnormals. All right, so patients who have undergone organ transplantation have to use immunosuppressive drugs long-term to prevent rejection. So that's things like prednisone or calcineurin inhibitors like tacrolimus. So a chronic state of being immunocompromised from these drugs can increase the risk of infection or reactivation, as well as reduced HPV clearance, and these can all lead to CIN. And cervical cancer is the second most common cancer reported in female patients post-kidney transplant. So most of the literature you'll find on cervical cancer is focused in kidney transplant patients, and the rate can be up to 2 to 3 times greater. It's thought to be related to the reduced ability of the immune system to recognize the cancer cells and stop their growth, as well as impaired ability of the immune system to inhibit the replication of cancer-causing viruses such as HPV. And there are studies that show that in situ cervical cancer rates, which is cancer confined to the cervix, while they may be higher in renal transplant patients, there are other studies that show rates of invasive cervical carcinoma, which is invading surrounding organs, is not higher, and that's simply due to increased cervical cancer screening. So while there may be need for more clarifying research on the exact risk of cervical cancer, several organizations recommend that patients should receive, quote, more frequent screening. But the American Society of Transplantation goes further and says we think they need annual pap smears and pelvic exams. And given the recent change in interval screening for age groups and using co-testing, it is understood that additional studies are needed to figure out if we can apply those to this population. Okay, so homeless women die from cervical cancer at a rate of 6 times the general population, which is quite high. And this came from a study performed at Boston Healthcare for the Homeless Clinic, which publishes a lot of excellent data on their homeless population. But overall, there's a scarcity of research in general on cervical cancer in homeless patients, likely due to unique barriers of accessing this population and retaining them in care, in addition to enrolling them in research studies. So the risks for cervical cancer in homeless women are primarily related to having HIV, multiple sexual partners, and smoking. Rates of screening have been found to be about 50% compared to 83% screening rates for those who are insured and 62% for uninsured women in the U.S. The reasons for not getting screened are, poor access to care, financial issues, transportation scheduling issues, and what the actual source of care is. But internal barriers could be denial of healthcare needs, mistrust of the healthcare system, and intense pressure of competing needs to obtain food, clothing, and shelter. And so also difficulty in following up in the actual test results is tricky because of transients and these life stressors. So communication of abnormal PAP results could never happen, or be delayed too far. So we recommend that even more for this population, if any, that really should have a discussion about cancer screening at all visits. So that means maybe performing same-day PAP tests if they walk in for a cold or a rash, and involving all staff members from the front desk to the back of the exam room. Are you up to date on your PAP screening? Have education on the walls in the waiting room. Integrate behavioral health to help patients who might decline screening when it's offered, and practicing trauma-informed care. Just there may be a high probability that patients have experienced physical or sexual trauma in the past, which can make pelvic exams uncomfortable. And the follow-up needs, make sure those are communicated, whether that's scheduling a return visit just to review results or giving the patient a card that has their PAP result and the date of the next due. So prior CIN2 or higher, these patients have a 2.8-fold higher chance of invasive cancer for up to 20 years after treatment. And this is encompassing the histological classification from the cervical biopsy of CIN2, 3, or CIN2, 3, 2,3. And those are just different ways that histologists have classified the tissues. And sometimes it's very difficult to tell the difference between a 2 and a 3. So the 2,3 encompasses those. So you want to educate patients that these classes, they don't mean they have cancer. They're just precursors to cancer, but we do need to keep an eye on them more than the general population. So here's a picture of just some of those aceto-white changes that you can see after colposcopy. And treatment typically consists of laser excision or ablation, or just excision or ablation of the affected tissue. So ASCCP and ACOG recommend that women should have routine age-based screening, which does not have to be annual, for 20 years after the post-treatment surveillance period. And the initial post-treatment surveillance period is typically co-testing at 12 and 24 months. And if those are both negative, then you can co-test in 3 years. This is also a change. We used to recommend annual screening. And different organizations have also differed on how they agree with these. And some providers may feel more comfortable doing annual screening for certain patients, maybe in the first 5 years after treatment before they extend the interval. And ASCCP does recognize this need for clarification and mentions it in their guidelines. And if there is any question, you can always consult a gynecologist or oncologist. All right, so our final population. It is estimated that 5 to 10 million pregnant women and children born to these women were exposed to non-steroidal estrogen diethylstilbestrol, or DES, between 1940 and 1971. It was given to prevent miscarriages or premature deliveries, and they thought it would help because they thought those things were related to low estrogen. But it was found in the late 60s that females born to mothers who ingested DES developed clear cell carcinoma of the cervix and vagina at a very young age, so the drug was discontinued. And so those children of the mothers would be about 46 to 77 years old at this time. And this pharmaceutical ad is very interesting. That was in an American Journal of Obstetrics and Gynecology in 1957. So patients exposed to DES have an increased risk of developing abnormal cells that can be precursors for a clear cell carcinoma, or CIN. Clear cell carcinoma does not have the same HPV precursor as CIN. Symptoms may be abnormal vaginal bleeding, discharge, or a red fleshy lesion. And the risk of HSIL has been found to be increased to almost twofold in DES daughters. And then one study did show that DES women were 3 times more likely to not have had a pap smear in the past 5 years. This was associated with older age, lack of education or health insurance, and not having a prior dysplasia diagnosis. So while you might not encounter too many of these patients in your practice, it's good to know there's separate recommendations. ACOG recommends annual pelvic exams and cervical cytology. National Cancer Institute and expert opinion recommends to also add a vaginal PAP, and there's no upper age limit identified at this time for when to stop. Okay, so real quick, we just had new guidelines updated in December from the Advisory Committee for Immunization Practices for HPV. And basically right now in the U.S., they're only producing the 9-valent vaccine. So other countries may still be using bivalent and quadrivalent. So they say, though, that anyone who started on the bi or quadrant who needs to complete their series can use the 9-valent. and that there's no booster needed for people who completed the series with the bivalent or quadrivalent. So the major points are that data supports non-inferior immunogenicity for people to have 2 doses between the ages of 9 and 14, excluding immunocompromised patients, which is great because it's not as expensive and you don't have to bring back people as often. But also in this new guideline is mentioning transgender patients. So it's noted that recommendations are the same as all adolescents, so 2 doses until 15 years old, then 3 for 15 to 26. And similar to the previous recommendation for men who have sex with men, routine vaccination recommended up to age 26 for this sexual orientation. All right, so I know we're running short on time. Caitlin, should we do the case study or should we do questions?
I think we can go ahead and do the questions just so answer some of the people's questions.
Sure.
So
okay.
Let me open up that box for you.
Okay.
Great. So at this point, we will start taking questions that have been entered into the question box.
Okay.
Our first one is from Chloe, who asks, do self-collected paths lead to accurate test results?
So that's actually sometimes. So there's a lot of research going on around this field, and especially international. Some other countries have adopted this sooner than we have. We haven't. It's found that there's a lower false negative rate for HPV collected tests versus cytology, and an increased sensitivity for self-HPV tests for invasive cervical carcinoma. So you can look up many tests, and there's a lot of variables to determine whether they're more sensitive or more specific, but there's a lot of really encouraging data. And yeah, so I would say stay tuned, and I think we'll have a change to our guidelines in the next few years.
Great, thank you so much. Our next question comes from David, who asks, what is the process of administering self-collected PAP, and is this an option that should be given to all patients?
So, really, so when you, again, different research studies, you either do self-PAPs, so they literally have, and you can Google this and you can actually buy it. It's a little cylinder that you insert into the vagina, and it kind of cups around the cervix, and there's a brush inside, and the brush just, you twirl it, and then you put it in a container and you mail it off. Others are swabs that just swab the vaginal wall for HPV, and then again you put it in a container, send it off. And in terms of all patients, I would say that the clinicians I know who use this, it's really just trans men who may have never received penetration or are just very disconnected from that part of their body and can't tolerate a speculum. It's just the only way that the test can be done. But I definitely, at this point, would not expand that to other patients who can undergo the typical, cell collection.
Perfect, thank you. Our last question comes from Joanne, who asks, how has HPV immunization affected cervical cancer rates?
Yeah, I think it might be too early to tell. I know one of the challenges is that there is disparity in who gets the HPV vaccination, and it's in some places it's mandatory to have the vaccine before you go to school, and other places it's not. And as you know, cervical cancer takes a long time to develop after persistent HPV, so I don't think we actually have enough data right now to know for sure.
Yeah, and they're also looking at how that would affect screening guidelines. So there's definitely research going on related to that.
Perfect. Thank you both so much. At this point, we will move on to the key points, but folks should feel free to email education@arhp.org with any additional questions they might have. And also, please feel free to view this presentation again, including the case study in core on arhp.org. Jill, would you like to review the key points before we conclude?
Yeah, sure. So hopefully the presentation has alerted you to special populations that need a little extra attention to increase screening rates. So whether that's, learning new guidelines for people living with HIV, or being sure to ask a trans man if he still has his cervix, hopefully these have, sparked some flags in your brain for future practice. Make your clinic welcome to diverse populations. So posting non-discrimination policies on the wall, hiring people of sexual, gender, racial, or ethnic minorities, and having patient education brochures relevant to people of all backgrounds. And then practicing patient-centered care. I know that gets thrown out a lot, but really involve the patient in the decision-making, and you have to spend a little extra time educating them on why cervical cancer is important to them as a person, to kind of get their buy-in. And then broaden your care team to include peer navigators, behavioral health members, so that they can address the other social determinants of health that can become barriers to patients receiving cervical cancer screening. That's it.
Perfect. Thank you both so much for joining us today and for that excellent presentation. Before we end today's webinar, I just have a few more important reminders for our participants. For more resources on cervical cancer, please be sure to visit us online at arhp.org. You will receive an email from Caitlin Borzowitz in about an hour containing a link to the post-test survey. Your CME or nursing CE certificate will be generated at the end of that survey. Be sure to print the certificate before closing your internet browser. If you have questions, just email us at education@arhp.org. Thank you again for joining us today. We hope you will take part in other live and on-demand sessions hosted by ARHP.